Yeah, my discussion today will be basically to make you understand the concept of bleaching and take away the fear that is there in your mind regarding bleaching. So I'll be going into the basics more rather than the higher end discussions much. So as and when whatever queries you have, you can share it with the moderator, and at the end of the discussion, I can get back to you. If any slide you are not able to understand, also please inform the moderator. We'll go about discussing it in detail. So let's start by the topic by discussing what is a smile. Now, majority of the patients who come to our practice would always want to have a frank smile. Now, a dictionary says that it is a kind, amused expression which is shown in the corner of the mouth. Now, if you look at the pictures that I've given you, there are a multiple amount of pictures which have been displayed. But which is aesthetic to us is the question. Now, that depends from a patient to patient. What aesthetics to you might not be the aesthetics that the patient wants. So we will have to have an open discussion with our patients before we progress with aesthetic dentistry. So as I use the word aesthetic, let's split up dentistry into two. There are aesthetic dentistry as well as cosmetic dentistry. I have highlighted a certain portion here where it defines aesthetic dentistry as art and science of dentistry, which is applied to create or enhance beauty of an individual without functional and physiological limit. That means it is just the appearance that the patient is concerned about, not the functional or physiological limit. Whereas cosmetic dentistry involves improving the not only the appearance but also patient's teeth, gum, as well as bite. So where will bleaching come? Bleaching comes under the section known as aesthetic dentistry, where it does not have any role in the function or the physiological limit. It is just the aesthetical or the appearance portion of your patient. Now, the most commonly asked question, is tooth whitening and dental bleaching the same? Now, when this topic was given to me, I went about searching about this. Now, it says that tooth whitening is our normal oral prophylaxis and polishing of the teeth that we do, by which the tooth gets its natural appearance. What is dental bleaching? Bleaching is a continuation of tooth whitening. That means after scaling, you do a polishing and then you expose the tooth to a particular chemical by which the tooth does not just appear natural, it will go a little more lighter than your natural tooth appearance. So whenever you discuss tooth whitening can be used as a synonym, but it definitely is different from dental bleaching. This is how I have split my topic into. As you had asked me about ABCD, I have split my presentation also under A, B, C, D, and E. So as we do for all presentations, there is a definition where, as I mentioned, lightening of the color of a tooth through application of a chemical agent to oxidize the organic pigmentation in tooth is referred as bleaching. So what we have to understand is we are applying a chemical agent on the surface of the tooth by which it oxidizes the organic pigmentation and the tooth appears lighter in color. So before I go into bleaching, you should know about discolorations. Now, discolorations are basically divided into two types. I'm not reading the definition part because you all know what the definition of discoloration might be, because you will have patients coming to our practice telling the color is different. The one tooth looks darker than the other. I have been brushing twice, but still it is not getting corrected. I've been using paste which says for brightening, etc., but there is no change. So it can be due to many reasons. So we start with classifications of discoloration. Basically, there are two types of discolorations. One is known as extrinsic and the other is known as intrinsic. As the term says, extrinsic means they are located on the outer surface of the teeth, which can be removed by our oral prophylaxis and polishing procedure. Whereas intrinsic stains are located within the teeth, especially in the deeper internal aspects of enamel, and the tooth can be viable and non-viable, but they usually can't be corrected by our basic oral prophylaxis and polishing. So first and foremost thing that we need to classify is, once a patient comes to you with a discolored teeth, we have to divide that as extrinsic and intrinsic. Extrinsic can be managed by oral prophylaxis and polishing, intrinsic cannot be managed just by our oral prophylaxis and polishing. Now, this classification you would not have seen in majority of the places. That is why I included it here, because it is said that the staining of teeth can happen because of dental procedures. Because we do not only do endodontic procedures, we also do restorations. Now, what happens when we do an endodontic treatment? Endodontic treatment are usually done on teeth which are either badly mutilated, or it has been fractured, or it has to be done because of tooth preparation. Now, when any of these reasons, basically the tooth becomes non-vital. So you need to retain the tooth inside the oral cavity. If you have to retain, the only option of retaining it without the tooth getting infected is by treating it endodontically. So what happens when you do endodontic treatment? Endodontically related pulp tissue remnants or intracanal medicaments or obturating materials can stain your teeth. Coming to restorations, old amalgam restorations, metallic posts and pins, and naturally discolored composites. Now, the newer generation composites are different. The newer generation composites are hybrid composites where you have filler particle sizes up to nanometer size by which polishing can be possible. But in the older generation, where we used to do composite restoration, the junction between the tooth and the composite is the most vulnerable area where the tooth can get stained. So what happens if you have something like that? You should think about replacing your restoration, then correcting by giving a new restoration, and then only think about whether you need bleaching or not. Now, patient related, we have already discussed, it comes under our intrinsic stains itself. So this is a classification which all dentists should keep in mind. Imagine I have a patient whom I had done a procedure who comes back to me after a year or so complaining about discoloration. We should always look for these, whether we have done an endodontic treatment, whether we had done a restoration, which can be the reason why the tooth is appearing discolored now. So the discoloration can also be classified into the based on the eruptive phase of teeth, that is pre-eruptive and post-eruptive. Pre-eruptive means just before the eruption. So that can be because of any diseases, it can be because of medication, it can be due to fluorosis, and usually it is enamel hypoplasia. Post-operative means the tooth has erupted into the oral cavity. So it can be trauma, it can be primary or secondary caries, it can be loss of tooth structure due to erosion, attrition, or abrasion. It can be because of discolored dental restorative material. It can be aging, and it can also be antibiotic reasons. So why I am stressing on this discoloration is because you have to identify what is the cause of discoloration. I will be going in detail as we go about case history taking and all, where we have to learn how to identify the discoloration. Coming to classification of extrinsic stains, this is the most commonly accepted classification, which is known as Nathu's classification, which I've just added because of academic interest, because as I am going into the discoloration, I just wanted to add this so that we will be able to differentiate between intrinsic and extrinsic stains. Now comes color. This is something which is important. Whenever a patient comes to you with a discoloration, we should try to understand the staining that has happened on the teeth. Now, I hope you would have understood by the extrinsic and intrinsic term by now. Extrinsic stains are stains which can be removed by scaling and polishing. So there you can divide them as two, direct stains and indirect stains. Direct stains means due to tea, coffee, other foods, especially smoking, plaque, and poor oral hygiene. And how do they appear? They look like brown to black, yellow to brown, or either black in color. Indirect stains means the stains which are found on the tooth surface because of some antiseptic agents that we use, which is not diluted. That is, after a good oral prophylaxis, we usually inform the patient to start with mouthwashes. Imagine if the mouthwash is not diluted to the correct ratio, the detrimental effect is the tooth might get stained, and usually they appear as black and brown. Next comes intrinsic discoloration. I'll go one by one. One is metabolic causes, that is congenital blood dyscrasias, the tooth might appear as purple or brown. Amelogenesis imperfecta, it is one of the commonly seen problems that we have in certain parts of India here. I don't know how the distribution might be in your place, but amelogenesis imperfecta is commonly seen. The most detrimental problem is enamel is defective. When the enamel is defective, our particular treatment is totally contraindicated because we need good thickness of enamel whenever we try to do bleaching. And the discoloration is usually brown to black in color. Next comes dentinogenesis imperfecta. Here, the opposite thing is happening. It is not enamel, it is dentine that is having a discoloration. Tetracycline stains are usually seen when the kid is exposed or when the mother is exposed when the baby is in the fetus, by which a discoloration of tooth happens with time. Next comes a very important thing which I had actually gone through when I was asked to take a topic with you, which is fluorosis, where I found out that there is a good percentile of fluorosis that happens in your side of the country. It is happening in our places also because of the water fluoride content, which is at higher level, which is known as fluorosis, which is again a condition where the enamel is weakened. And we have to be very careful when we think or decide about bleaching. And literature says about 28% of individuals in Ethiopia suffer from fluorosis. Now I go on to the latter end of it, which is internalized discoloration, which is caries and restorations. Hope it was clear the A section which we have discussed, which is the commonest. How do you classify discolorations? How do we identify discolorations? By this only can we make a step forward by which we'll be starting off with what are the different materials, what are the different mechanisms of bleaching. Now, this is again just for academic interest. When bleaching had started, initially it was used in a liquid form. But the problem with liquid form is the bleaching agent that we use should be in contact with the teeth. So to get utmost contact, a liquid material will not stay in the mouth. Why? You have saliva. However, we try to keep away our gingiva, our soft tissue away, it can spread to the soft tissue, which can lead to primary degree or secondary degree burns. So initial form which was available was the liquid form, which had to be changed because it does not adhere or stick onto the tooth surface. So the second generation came in, which are viscous or available in gel form, where the agent is in a more concentrated form. It gives more contact time by which the coverage of tooth structure was more evident and bleaching was more effective. Now we have a third generation where it is similar to second generation, but it also indicates us that it is time to change the gel by a change in color. That is a white colored gel which is applied on the tooth surface. Light is exposed. As time progresses to the ending of bleaching, it usually changes its color to red or green, depending upon the manufacturer that we select. So this is how generations of bleaching agents are. First generation was available in a liquid form. The problem was the difficulty in application and difficulty in control of flow. Hence came the second generation, which is the gel form, by which the application became easy, total coverage of tooth was possible, and the result was more predictive. Third one is the third generation, similar to the second generation, which is available in a gel form, but it also helps the doctor identify that the bleaching is over because the bleaching agent will change in color. Now we'll go into what are the different types of bleaching agents. The active ingredient of tooth bleaching agent is a peroxide compound. So it has to be a peroxide. While currently a variety of bleaching materials are available, the most commonly used peroxide compounds are first hydrogen peroxide, second is sodium berborate, and the third one is carbamide peroxide. So we have to learn, or I would like to impart these three agents specifically because hydrogen peroxide and carbamide peroxide are used for extracoronal bleaching, whereas sodium perborate is used for intracoronal bleaching or otherwise for teeth which are root canal treated. I'll be going in detail about this. So let's start with hydrogen peroxide first. It is a colorless, odorless liquid which should be stored in a light-proof amber bottle. It is very, very clearly mentioned that it has to be colorless, it's a clear, odorless liquid, and it needs to be kept in a light-proof amber bottle. What will happen is, if it is exposed to light, the chemical reaction can set off, by which the free radicals can be released and the bleaching potential might come down. Peroxides can be classified as organic and inorganic. But the most important part, or what we should understand, is the last statement which I have given. That is, it has a lower molecular weight. Hence, it can penetrate dentine and release oxygen that breaks down carbon double bond of inorganic and organic compounds inside the tubules. Now, when we understand what is bleaching, bleaching basically is the discoloration that we perceive from our eyes. So here we should go back to our physics class a little bit, where we have learned about absorption, adsorption, reflection, etc. Why does a tooth appear dark? Is because it absorbs light and it does not release light much. That is why it appears to be dark in color. Why does it appear dark? Is because there are carbon double bonds or molecular higher weight light back. Hence, the tooth appears dark. So when we apply hydrogen peroxide, it releases free radicals which break these double bonds, make them into single bonds, by which the tooth starts to appear lighter in color. What is the range that hydrogen peroxide is usually available? We get hydrogen peroxide in the range of about 5 to 35%. Even 3% hydrogen peroxide are available, which sometimes we use in endodontics in combination with other irrigants. But concentration that we need for bleaching is in office. That is, when the bleaching is done by or in assistance with the dentist, the concentration that we should use is around 25 to 38%. And the concentration, if the bleaching is done at home, should be 3 to 7.5, sorry. It is because higher concentration can be applied in the dental clinic because you are there and the process is happening under your observation. So if you feel it is causing a caustic effect, you can stop it then and there. Whereas if you give an agent to the patient and ask them to apply it at home, and imagine if you give a higher concentration, then whatever damage that the tooth is causing or the damage that is caused to the tooth, it cannot be reverted back. I'll be showing you certain images, or I'll be showing you the chemical reaction where you should stop and what will happen if you don't stop. Now, I have shown a picture here. Can you see? I hope it is clearly seen. The fingers look, or they have a patched appearance. This is because of a chemical burn that has happened because of contact with high concentration of hydrogen peroxide. So whenever you handle hydrogen peroxide, proper personal care has to be taken. Proper gloves have to be worn. Make sure the bleaching agent does not fall on your patient. The patient should be properly draped. Eyes should have protective agents. And be careful that we don't apply it on the lip, gingiva, etc. So as I said, in the classification, the hydrogen peroxides are available as liquid as well as in the gel form. Liquid form, as I said, they are available around 30 to 35% is the form. When it's given in gel form, if applied at home, it should be 6. If applied in the clinical setup, it should be around 30 to 35%. Now comes the second agent, which is known as sodium perborate. It is a stable white powder, which is normally applied in a granular form that has to be grounded into powder before using. When I had started, or when I was in my college days during my post-graduation, sodium perborate was not available in the packaged form. Now it is available in packaged form where we can get it from our chemist. Previously, it was not available that freely. So then we used to get it from the chemist at the percentage that we want, and then we used to use it. Sodium perborate is usually used for walking bleach or used for bleaching in root canal treated teeth. Now, how does this function? When this mixture reacts or mixed with water and is used inside the teeth, when it comes in contact with water, it to give sodium perborate and hydrogen peroxide and oxygen is released. So hydrogen peroxide is the agent that is active here again. Though we say sodium perborate breaks down to give hydrogen peroxide, and hydrogen peroxide is the bleaching component that helps us achieve bleaching. If not mixed with water, it can be mixed with superoxole. Superoxole is nothing but 30% hydrogen peroxide. Sodium perborate can be mixed with hydrogen peroxide and can be placed inside the teeth, where it decomposes to sodium metaborate, water, and oxygen and helps us give bleaching. What is the advantage? It oxidizes the stains slowly. So what did I say? Sodium perborate is usually used for bleaching of endodontically treated teeth. So where we want the hydrogen peroxide to act, but in a slow fashion. That is why it is used in walking bleach technique. It is more easily controlled and is safer when compared to concentration of hydrogen peroxide. Therefore, it is a material of choice in intracoronal bleaching procedure. Please, by the end of this discussion, we should at least understand that hydrogen peroxide is for direct bleaching or home bleaching. Whenever you hear the term sodium perborate, it has to be used for endodontically treated tooth or otherwise known as intracoronal bleaching procedure. So as we have finished two of them, we come to the third material, which is known as carbamide peroxide. It exists in the form of white crystals or in a crystallized powder containing approximately 35% of hydrogen peroxide. Its concentration ranges from 10 to 30% depending on whether it is at home or in office. So whenever you see the concentration, please keep in mind 7 to 10 is for home. Anything above 10 is to be used in office. Commercially available preparation has 10% carbamide peroxide. And usually we add glycerin or propylene glycol to make them into thick format, and it is added with citric acid, phosphate, and flavoring agents. Carbapol, a very important agent, is a water-soluble polyacrylic acid polymer which is added as a thickening agent as it prolongs the release of active peroxide and improves shelf life. Now, I would like to stress on carbapol. Whenever we see a bleaching agent, I have added that in my slide that whenever we buy a bleaching agent, please don't discard the paper that comes along with it. Please read through what all are the agents which we have in it, what is the composition of it, what is the shelf life of it, because shelf life is very, very important. Imagine never use an expired material for bleaching because it can give you a very, very detrimental effect. And carbapol is very safe. It makes the gel thicker. It is water soluble, hence removal is easy. And it is a thickening agent by which the application of agent of your bleaching agent on the tooth will be easy. So this is the basic thing again as a consistent whatever I have discussed till now. Remember always about hydrogen peroxide, carbamide peroxide, and sodium perborate. Now comes the important part of it. Now, when I had a discussion with Dr. Meron and other people from your side, I came to know that the bleaching is happening not only in the dental offices, but in other places also. Now, why are we termed as dentists or specialists? Is because we are not only trained in using a material, but we know how to use the material also. So, I don't know how you people motivate your patients. I personally tell my patients that this is a procedure that should be done when you are at the center stage. That means when the patient has a higher involvement with public, especially because I have a clientele of patients who are working in news agencies, who come on television very frequently. There are celebrities who always want to have their teeth white. Now, this is a procedure which needs to be done very carefully because hydrogen peroxide, when applied on enamel, will cause a little detrimental effect on the enamel, as well as it is a reversible process. That means a celebrity who has got a Hollywood smile might have to do bleaching every year or at a particular interval to keep up the smile, because this tooth that we are doing bleaching on will have or has a tendency of coming back to its original color. So let's start with the mechanism. As previously said, hydrogen peroxide always splits up, it releases free radicals. These free radicals are needed for bleaching to happen. So if bleaching has to happen, hydrogen peroxide has to break. And if hydrogen peroxide breaks, they release free radicals. The principal mechanism is that oxidizing agents reaches the site within enamel and dentine and allow a chemical reaction to occur between discolored segment and the active ingredient. Hydrogen peroxide diffuse through enamel, release free radicals which are generated. They interact with the organic molecule to attain stability. Bleaching agents open the more highly pigmented carbon ring. This is what I mentioned. Usually these pigments are carbon double bonds, which give the yellow kind of a color for the teeth. These are converted them to carbon single chains. These double bonds are broken down into single, by which absorption of light becomes lesser and the tooth appears lighter in color. So if anybody asks you what's the mechanism of bleaching, it is that the hydrogen peroxide or the non-hydrogen peroxide that we apply usually releases free radicals which cause bleaching. As I previously said, the tooth appears discolored because of certain double bonds which are formed within the teeth. The hydrogen peroxide that we apply diffuses through the enamel matrix, reaches these carbon double bonds, break them into single bonds, by which the tooth appears lighter in color. This is a split up of what I had given in sentences. That is, it is a redox reaction that happens where tooth is the reducing agent and bleaching is the oxidizing agent. The oxidizing agent acts on the reducing tooth structure, releases free radicals with the unsaturated bonds. Larger stain molecules are converted into smaller ones. Simple molecules are formed which reflect less light or become colorless, by which the tooth appears whiter in color. In addition to the chemical reaction, there are small changes that happen on the tooth surface also. There is some amount of cleansing of tooth structure. A temporary dehydration happens on the surface. And as I said, change on enamel surface. Definitely there will be change in enamel surface. Hydrogen peroxide acts as a strong oxidizing agent through formation of free radicals, reactive oxygen bubbles, and hydrogen peroxide anions. Now, this is something which I wanted to really discuss with you with a little time, because if I say, you can see that I have put it into three distinct parts where you have a chemical reaction being shown, an explanation being shown, and a visual examination also of how the tooth changes into from discolored to a colored or a lighter shade. The chemical reaction, as I said, when a bleaching agent is applied, the bleaching reaction starts. It splits up the double bonds into single bonds. I hope it is seen in the picture that when hydrogen peroxide is applied, bleaching starts, by which these double bonds are broken into single bonds. So explanation is darkly pigmented carbon ring structure, lightly pigmented unstructured or unsaturated structure, and hydrophilic non-pigmented structure, or it reaches a point which is known as saturation point. In the previous slide, I told you we are called as specialists because we should know these agents, we should know when to stop, and we should know when it can cause a problem. The problem causing area is known as saturation point. That means this is the point where you should stop your bleaching. Why? I'll explain. I'll finish this and I'll explain it to you. This is how the change happens on tooth. You can see a dark pigmented one on exposure or on bleaching becomes lighter. And this is where you should stop, where completely bleached stains are removed. Now comes over bleaching. That is, I told you there is a point where we should stop. If we still continue it, the glistening on the tooth surface is lost. It almost appears like a chalky white kind of an appearance. And if it still again continues on, or when you go into chronic bleaching, the whole picture is different. Can you see any bonds in this particular picture? No bonds are seen. That means it totally breaks it up, by which the enamel itself can give way. That is decomposition of molecular structure leading to complete oxidation. That is, it breaks down the enamel matrix, it splits the tooth surface into carbon dioxide, loss of enamel matrix, and water, by which the tooth can be denuded of enamel, which is a very, very detrimental position where the what you had applied bleaching agent to make the tooth white. The tooth is not just white now, it becomes of a stage that the enamel itself can be worn off from the tooth structure, causing severe complications for the patient. Now, this is the change, or this is where we should be different from other people who are practicing this kind of bleaching in your part of the place. You should know you should stop and where you should start, or where you can repeat a cycle before you stop that particular appointment, and you can appointment later on and repeat the same cycle, rather than continuing it to an extent that it can be detrimental to the tooth. This is how the bleaching agent permeates through the teeth. You can see that, as you all know, inorganic component is more in enamel. So it permeates through the inorganic component as well as dentine. Now, there are certain factors which affects bleaching. The factors are surface cleanliness, type of peroxide, concentration of peroxide, shelf life of material, temperature, pH, time, frequency of application, sealed environment, additives, and what are the age and initial color and major rules. This I'll be discussing as we go about discussing each technique in detail. So I guess I have been able to convey the B part to you, which is what are the three basic agents that we have which needs to be used in bleaching, what are the concentrations, and where you should start your bleaching, when you should stop your bleaching before it becomes detrimental. Now I go on to the C portion of our discussion, which is diagnosis and treatment planning, bleaching techniques, indications and contraindications of bleaching. Diagnosis and treatment planning is very, very important. A patient walks into your dental office and asks for bleaching. You should first confirm that this particular candidate should be taken for bleaching or not. That conclusion can be reached if our diagnosis and treatment planning is correct. So, first, patient education and an informed consent. The informed consent part is very, very important in when it comes to practicing dentistry as well as medical side, because the patient will have a certain hope. Now, we should be able to convey to the patient that there is a limit to everything. A patient who comes with a B2 shade asking for an A1 shade is not possible, or is possible only after repeated bleaching. That has to be conveyed to the patient. And the patient should also be well versed about the technique, the agent that we apply, and the problems that we can come across and how it can be managed. So a careful diagnosis by visual examination indicates the cause of dental staining and the extent and depth of discoloration. Here is what our initial slides come into role, where we have to identify whether it's an internal stain or an external stain. If an external stain, clean it, polish it. If the patient is not happy, wants yet lighter shade, is the only point where you should go for bleaching. Coming to behavioral history, previous and current use of tobacco, coffee or tea, and highly colored beverages and foods. Imagine the patient of yours who is coming into our office is a chronic tobacco user, a chronic coffee or a tea drinker, and a person who uses aerated drinks like Coke, Pepsi, or is a foodie who eats a lot of acid-based food, in those kind of conditions, they can cause problem because the discoloration can repeat. That is, once bleaching is done, I told you there will be certain enamel changes that can cause discoloration again. So in those patients, we have to inform them that you will have to discontinue your habit. Or imagine if it's a smoker, ask them to discontinue the habit. Coffee or tea drinker, ask them to wash their mouth immediately after taking tea or coffee. Same thing goes for colored beverages also. Advise them to immediately swish their mouth and make it clean so that the colorants don't stick onto the tooth and cause a discoloration. Coming to medical history, focus on any systemic problem or medication that might have affected this particular individual. Problems begin during critical period of tooth development, needs to be investigated through prenatal period. That is, I told you in the history, like tetracycline stains or any heavy fever that has happened to the mother during the fetal stage of the kid or the individual can cause internal staining, which might not be able to be managed only with bleaching. So in those conditions, we have to discuss it with the patient, make them understand it, and then decide about our treatment. Determining soundness of the individual teeth. First is vitality. Second is periapical or other pathological conditions. Third is caries, and the fourth is defective restorations. All 4 points are very, very important. Vitality, because you have to know whether the tooth is root canal treated or a normal teeth. If root canal treated, then our bleaching technique should be different. If the tooth is viable, our bleaching technique will be different. Periapical and other pathological conditions, imagine the patient as a periodontally compromised patient or an endodontically treated teeth with repetitive abscess. That has to be corrected first. Any pathological condition that is present inside the oral cavity should be managed first before we go into bleaching. Next is caries. Imagine we are doing a bleaching from canine to canine or premolar to premolar, and the individual has a class 1 or a class 2 caries or a class 3 or a class 4 caries. The caries has to be removed. A restoration has to be done before we plan our bleaching. Defective restorations, fractured restorations, secondary caries affected restorations have to be removed after cleaning and after scaling and polishing. All these defective restorations should be corrected, and then only the individual should be subjected to bleaching. Record keeping. This is very, very important when it comes to bleaching, because I told you, patient comes to our dental office with very, very high hopes. So they will want a certain result. We might deliver the result, and then the patient comes back saying that my neighbor or my mother said the kind of shade which I wanted has not been delivered. So that you have to keep a shade tab next to the tooth. That's why I kept the picture. You have to keep a shade tab, match it with the natural tooth shade, and make them understand the kind of change that we have been able to appreciate. Then only the patient will understand. If possible, share these pictures with your patient so that they can keep it as a record. You can also keep it as a record, and you can understand the difference that has happened in each stage of your treatment. Help the patient to later recall how he or she looked before any treatment, and to recognize the cumulative effect of what may be a gradual improvement in tooth color. Gradual change is what happens in gradual changes. Usually when we give the patient at home or walking bleach, the change will be a little slower. So the patient can get impatient. So you will have to take repetitive photos so that they understand the change is happening and the change is a gradual one. Whereas an in-office one, in that appointment itself, the patient will get 2 shades lesser. If needed, one more appointment, 2 shades lesser. So the patient will know what is happening inside the oral cavity. Now, coming to classification of bleaching techniques, based on vitality, we can split them as vital and non-vital. And based on where it is performed, we split it as in-office or walking bleach, otherwise known as dentist prescribed or even home applied bleaching. So I hope I'm clear till here that the history taking, understanding the stain, how you record it, how you record the shade, is all important before you start or before you decide on your treatment plan. So first, I will start the discussion with vital bleaching, which is the common bleaching that we do in our dental office or home related one. So we can split vital bleaching into three. In office means it is done by the dentist in his operatory. Night guard or at home. That means here we give the patient a tray and the gel. Patient will take it home, apply the gel and apply it when the patient is at home. Over the counter are agents which you can buy from pharmaceuticals or otherwise known as medical shops and use them for lightening your teeth. Now, I would like to stress on this particular slide is in office, always remember the percentage will be higher. It will be around 30 to 35 and hydrogen peroxide is usually used. At home or night guard, always the concentration has to be lesser, should be around in a range of 6 to 10. What are the indications? Indications are discolored teeth due to mild fluorosis or tetracycline stain. In severe discoloration, bleaching could be performed to lighten the teeth color before restoration with bonded resin or porcelain veneer or crowns. I will spend a minute in explaining what that is. Imagine a patient comes to your dental office with a discolored lateral incisor alone, but the tooth is viable. You have checked the vitality, tooth is viable. So you might not, the discoloration has happened because of an intrinsic staining. It can be fluorosis where it has affected only that tooth, or it can be an enamel defect affecting only that teeth. You can bleach that tooth alone and bring it to the shade of the adjacent teeth. And then for permanent solution, you can give a veneer or a aesthetic crown after you do your bleaching procedure. I hope you have understood. I'll explain it again. In severe discolorations of one or maybe two teeth, not more than two teeth, you can do bleaching of these two teeth alone, bring the shade to a lighter one, and then you can think about a veneer or a direct bonded composite restoration by which the tooth will come to the shade of the adjacent teeth. In order to match the existing color of the crown that is lighter than the natural teeth. Contraindications. So just like our indications, contraindications are very, very important. I would say contraindications are more important when it comes to bleaching. Superficial stains that can be removed with rubber cup and prophylaxis. That means external stains or extrinsic stains which can be removed and the patient is happy, please stop it there. Don't have to go for bleaching. Do a bleaching only when the patient is not satisfied with the smile that the patient has got after our prophylaxis. Carious tooth structure or dark colored resin restoration. Imagine the tooth is discolored because of a caries lesion or a bad or a old restoration. Please remove the restoration, redo the restoration. If it is carious, remove the carious lesion, do a restoration, and then only, if needed, do bleaching. Older patients who complain of sensitivity are again a contraindication. If the patient already has worn teeth, has a tendency of or gives you a history of sensitivity on exposure to heat and cold, are not ideal candidates for bleaching. Children with large pulp chamber. Children, again, bleaching is contraindicated because the chamber sizes are bigger. Dentine deposition is not sufficient, by which the hydrogen peroxide can easily penetrate, reach the pulp, cause pain and non-vitality to the tooth. Again, don't do a bleaching for pregnant and lactating women, and never do bleaching on exposed root surface or in individuals who have got periodontal problems. As I previously said, material available are hydrogen peroxide and carbamide peroxide. I had specifically mentioned sodium perborate is never used for vital bleaching. It is only used for non-vital bleaching. So hydrogen peroxide, the concentration is 35%. It can be liquid or a powder form or a gel form, which is usually called as a power gel or a laser bleaching gel. Nowadays, they are available in gel form. Application is easy. Result is predictable. So I strongly want or I would suggest you to go for gel forms of hydrogen peroxide whenever you do a bleaching. Next is carbamide peroxide, which is again 35%. Various concentrations and combinations of the above materials are available. Similarly, even dual activated bleaching agents are available. That is, they start the reaction when light is applied on them and they are chemically activated. Just like our composites, where you know that a blue colored light at a particular wavelength has to fall on it so that it gets activated. And after that, it is the chemical reaction within the agent which causes the bleaching to happen. Next are the steps of how you should prepare a patient in your dental office. First and foremost, familiarize the patient about the cause of discoloration, procedure to be followed, and the treatment outcome or the expectation that the patient should have. So imagine a patient comes to you with discolored teeth. First and foremost, inform him what kind of discoloration it is. If it is an extrinsic one, tell him, I will do a scaling, I will do a polishing. And then if you're not happy with it, we will go to the next step that is known as bleaching, by which we can bring down the shade of the tooth to this particular. Next important thing, make radiographs to detect presence of caries, defective restorations, proximity to pulp horns, and naturally if the patient gives you a history of root canal treatment. In all these cases, next step is take a radiograph. If you have a doubt of a proximal caries, please take a radiograph. If you doubt that the restoration, class 2 deep restoration is fractured or a problematic one, please take a radiograph. And even if there is enamel loss by which you think the pulp horns are at a higher position, you can take a radiograph. Next, after the first two steps, that is, the patient is ready for the procedure, you have taken the x-rays, that also the patient has cleared. Next is shade matching. Evaluate the tooth color with a shade match by taking a photograph at all the appointments. That is very, very important. Majority of the time, we forget to take pictures in between. We will take a picture in the first, and then we usually take the last one. What will happen? We will not know at what rate the bleaching is happening and what rate from where we started and where we ended up. Imagine your dental office has a lot of patients coming in. If you have a set of 5-6 patients where you have these photos with you, you will exactly know at what step or how many cycles you will have to give to attain that particular shade. Now, shade tab has been selected. We have reached or we have covered till stage 3. Next is stage 4. That is application of Vaseline or a C or Orosil or some lubricant in all the soft tissue area. Apply rubber dam by using waxed flosses, wedges for additional sealing. If not rubber dam, there are chemical dams which are available, which I'll be showing you in the video. I'll be showing you a video as well as pictures related to how they are applied and how they are to be removed. Avoid using metal clamps as they are subjected to heat, because the chemical agent that we apply, when it splits, there are some amount of heat formed. If you are applying light on the surface, there will be some amount of heat formed. So this heat can be conducted by the metal clamps, where that itself can cause damage to the soft tissue. So I hope this is clear that these are the steps that we go through when we prepare a patient. I'll repeat it once more. First, we understand what kind of discoloration it is, what is the preparatory steps that we have to do, and what is the final outcome that the patient has to expect. Next, take radiographs if needed for defective teeth, for defective restorations, and to know the height of your pulp. Next stage is where you take photographs along with shade tabs to know the change that has happened. Then you apply a gel form on the soft tissue area so that the gel, when the hydrogen peroxide gel comes in, should, even if accidentally coming in contact, should not cause a burn. Then retraction. We need to apply rubber dam in certain cases. Certain cases you can stick to gingival dams. Avoid using metallic clamps and metallic restorations also. Direct application of gel and light should be avoided. Now, I told you about gingival barrier. I have placed I have placed 2 sets of images. Let's see the first image first. This is how a gingival barrier should be placed. It should not be placed too much onto the root structure and neither too much onto the gingiva. And it should have a sufficient thickness. What textbook says is the thickness of your attached gingiva is what should be covered by our gingival barrier. Now, what has been indicated as wrong here is you can see that the gingival cone is exposed here. If that area is exposed and we apply gel or a properly applied one, the gel will never flow onto the gums. You will exactly cover all the tooth structure. Whereas if this kind of an exposure happens, that area or the gingiva that is exposed to the bleaching agent will also get bleached. This is a posterior area where I wanted to emphasize about importance of placing the barrier. You can see that barrier is being placed, suction is placed, and you can see a bite block is also placed. But still, once the bleaching agent is applied, you can see here that the bleaching agent is not restricted alone on the tooth structure. You can see that it has overflown, and once activated, you can see it is totally displaced from the tooth structure. So application of gingival dam and the agent is not sufficient here because of improper application and improper placement of gel. What went wrong here? Here, this is what is known as a gingival dam. I hope the arrow can be seen in my presentation as I'm moving the arrow on the screen. Doctor, can you see the arrow move on my screen?
Yes, it's visible, Doc.
Sorry, yeah, thank you. The green structure that you see is known as the gingival dam. Here it was the previous slide, it was a blue colored gingival dam that you see. It usually varies from different company or brand that we get. And in between, I told you there is a third generation bleaching agent. That is, once you apply it and the light is exposed, it changes in color so that you know that it is right time for the bleaching agent to be removed. You can see that the gingival dam was placed and the agent was applied. Here you can see in the second picture, the gingival dam is removed. The agent is completely wiped off. And what do we see? Can you see here? The gingiva looks white, just like the cotton pellet which was kept next to it. And that is what you see here. Can you see? Along with the tooth, the gingiva is also exposed to the agent by which the gingiva is also bleached. Here, here whatever defect had happened was superficial. It did not affect the deeper portion of it. Had it gone or had the concentration be higher, naturally you would have seen burns in this area. And be very careful in this kind of situation. Never rub that area with a gauze or a cotton because that area can get denuded if you give pressure. The same individual after 14 days, you can see it has come back to normal. So, but this is not to be done. Even though even though it happens at a lower degree, it can revert back to normal. You will just have to reassure your patient, but try to not cause this. And how can this be avoided? Is by proper application of your gingival dam and make sure your bleaching agent does not overflow onto your gingival dam. Apply 30 to 35% hydrogen peroxide liquid or gel on the labial surface of your teeth using a cotton pellet or a piece of gauze. Apply heat if it is in combination. Treatment time, if the concentration is lesser, should not exceed 30 minutes. 30 minutes is not one cycle. One cycle is only 8 to 10 minutes. Maximum you can do is 2 to 3 cycles in one appointment. Please don't do another after that. Even if the result is not satisfactory, please don't exceed that. Maximum is 3 cycles. Never extend to 4th cycle when you're doing bleaching in your dental office. Pumice is used on the teeth to remove the residual gel from the enamel surface. Remove the bleaching agent, irrigate thoroughly, dry the teeth, gently polish them with composite polishing cup. Apply neutralizing agent, which is sodium fluoride gel for 3 to 5 minutes. Very, very, very important, which is usually not indicated on majority of bleaching agents that we use. We should apply sodium fluoride on the tooth surface for minimum of 3 to 5 minutes to neutralize the effect of bleaching that has happened on the tooth structure. and instruct the patient to use a fluoride mouth rinse daily for at least 2 weeks, because I said the hydrogen peroxide has a detrimental effect on enamel when we stretch up to 2 to 3 sittings. It can cause some amount of demineralization. Fluoridated mouthwashes usually gives back some minerals that are lost from the tooth surface. This is a single picture which will show you the complete steps of in-office bleaching. First and foremost, apply a retraction of lips. You take a shade tab of the tooth or of almost 1 or 2 teeth to understand it. Apply a napkin around the patient's face, and naturally an eye protection is very, very important. You can also place cotton rolls in the areas to retract your lips. Apply the gingival retraction material that is available. Cure it with your light cure so that it becomes firm. Apply your hydrogen peroxide either with the brush or with the tip that is available with the brand. It can either be chemical or it can be light activated. You can see a light activation has been done and you can see the change in shade. Here, I would like to show you a video of an agent.
Opalescence Boost is a chemical.
You can, this opalescence boost is one material that I use in my practice. It is very predictable. It is safe when used if you follow the instructions correctly. Opalescence boost usually comes as two syringes where you have an activator and a base paste and an activator paste, and you have a gingival retraction to it. You can see the steps as I had mentioned in my discussion. Eye protection has to be done, shade has to be selected, proper retraction of tissue has to happen, a bite block has to be placed. Make sure the patient does not aspirate it. That's why you can see that a tie has been placed. This is the gingival retraction material that is usually available with the brand. It is green to blue in color. Dispense a little bit outside before you apply it on the patient. Moisten the teeth and dry it with the suction. This is how the gingival retraction cord be placed. And see, as I told you, the core area or the gingival heights should always be covered by the gel. Once the gel is placed in the upper, cure it, then only you place the lower arch. Once, and look for these pink exposed areas. They should always be covered. There should not be any area where this pink area should be exposed. After that, light cure the area so that it becomes hard or firm or rigid, so that it will act as, how do you confirm it? Confirm it with an explorer. Run the explorer, make sure it does not stick. I told you it comes in a two-tube system. One is an activator, another is a base paste. There is a lock for two of both the agents. You can lock it and you're supposed to pump it either way 25 times. The pumping in and out will mix the base paste and the activator paste, by which the chemical reaction will start. The manufacturer says 25 times. You push it in and out, by which both the gels will be mixed together. And then once you have done it 25 times, push all of that into one tube. Then take the applicator tip. You can please look at the applicator tip. They provide a specific applicator tip by which the tip will have a cotton or has got a soft delivering tip. Can you see that area? It has got a soft delivering tip by which application is easy. Please look onto the tip. It's just like our etchant, the etchant kind of a tube where the metallic portion is a bigger one, but the cotton tip helps us in uniform application of the gel on the tooth structure. You can see how it can be applied. When you apply that, make sure don't extend it into the green area and no teeth should be left uncovered. So apply once, then come back, see all areas and replenish the area like this, and keep a suction always beside, because salivation will happen. Saliva should be removed as and when. So once the first cycle is over, you can use a broad-ended suction tip to remove the gel from the tooth structure. Then you can use your three-way syringe, or you can use even saline in a syringe to rinse the tooth surface and make out the difference that has happened on the teeth. And in between, always clear your suction with plain water. Now you can have a look at the shade change that has happened. Imagine the patient says there is a bit of discomfort on this particular teeth or any teeth. Please stop it then and there. Imagine the patient says the patient that is not having any problem, would like to go ahead, want a different shade. Please go to the second cycle, and maximum is 3 cycles. Please don't go to the 4th cycle. Please stop it at 3. My personal opinion will be 2 applications. I usually stop with 2 applications in my practice because I never want to cause any detrimental effect to the teeth. But if the patient is an insistent one, please explain it to them that there can be some detrimental effect on your teeth. Try to educate your patient. So once the bleaching is complete, maybe 2 or 3 cycles, which we might have extended onto, wash the tooth surface completely off the bleaching agent, dry the teeth thoroughly, then you remove the barrier. How do you remove your barrier? Never use a sharp instrument. Never use an explorer or a probe because that can hurt your gingiva. So please use a plastic instrument or a filling instrument in your practice for removing these gingival dams in place. Once that is done, again show the patient the shade tab, and the patient would understand the change that has happened. I would advise you to show the shade tab at the 2nd cycle as well as, if needed, the 3rd cycle so that the patient will appreciate the change that has happened. Now, this is a case which we have done in our clinical practice. You can see this was the shade. After 2 cycles, we were able to achieve this shade and the patient was quite happy. So we stopped with the 2 cycles. Again, I am somebody who is very critical about whatever I do. You can see a small area here where I had my gingival dam placement was not correct, by which you can see a white spot that usually should not happen when you are doing it in your practice. This is another case of mild fluorosis. You can see a mild fluoride affected area here where we did bleaching only for the anterior teeth. Rest of the teeth were fine. So we didn't want to do a full bleaching. We gave a gingival barrier. We bleached only the anterior teeth, and you can see the result that we could achieve. Next comes the dual mode. Whenever you hear the term dual is not something new to our dentists. We always have been acclimatized to the word dual due to composites. We have heard about dual cure composites or composites which are initiated by light and then the continuation. It's the same thing here. The additive agent is ferrous and manganese sulfate have been added to the bleaching gel to allow for chemical and light activation respectively. There are different products which are available. One of the most commonly one is Highlight, which is supplied by Shofu. The HP gel changes color from blue to green or to cream, and finally chalky. A maximum of 6 passes are recommended in one session. But as I said, I will never recommend anything more than 2, maximum is 3. This is just a picture of that where you can see the change in color. When you apply it is blue, but later on it becomes chalky white in color. What are the common light sources which can be used for bleaching? Now, all of us have, or majority of us will have LED lights, or the older generation will have tungsten halogen lights in our practice. So tungsten halogen lights are the initial light curing units which were used for composites. How does it help in bleaching? It raises the surface temperature by which heat is there. It starts the chemical reaction. It is same with conventional bleaching lights also. Initially, when bleaching came into market, the lights were also promoted at a huge mass, where we can see bleaching lights in majority of the clinics. The bleaching lights are good because they cover only the oral area by which it will not, the light will not fall onto the patient's eyes. But newer agents which we have with advancement, now we have lasers also by which we might not need the conventional bleaching lights. But how do they work? They also work in the same way. They raise the surface temperature by heat, and they help in chemical reaction. Lasers, I'll be discussing in detail in the coming slides. So I hope you would have understood about in-office bleaching. Basically, in-office bleaching involves application of hydrogen peroxide on the tooth surface. Gingiva and tooth has to be protected when we do that. And the application usually is easy when you use a gel. And you have to be careful that you don't expose the gingiva to bleaching agents when you apply them. Be careful when you apply them. Be careful when you wash them off. Eye protection is very, very important. Soft tissue protection is also important. Educate your patient whenever you are doing it. Please don't do more than 2 or 3 cycles in one sitting. You can do repeated cycles. At what interval? Maybe 2 weeks or 3-week interval, you can do a repetitive cycle. Next comes the second technique, which is known as home bleach technique. That is, the patient does not want to spend much time in our clinical practice, is the individual who should be selected for home bleaching. At home or dentist supervised night guard bleaching. The term night guard bleaching came because the patient can apply this gel in the guard and can place it inside the oral cavity and dose off. That is why we call it as night guard bleaching. It basically involves use of a low concentration of whitening agent. Very, very important. Remember, you are sending the patient home with the gel agent. The concentration of the gel agent should be lesser. 10 to 20 for carbamide peroxide and 3.5 to 6.5 for hydrogen peroxide. So in general, it is recommended that 10% carbamide peroxide be used 8 hours a day. 15 to 25% is the concentration of carbamide peroxide. Then you should use it only for 3 or 4 hours. Why? The change happens with the concentration. So I personally would advise a 10% carbamide peroxide because even if we instill or tell them to use it for 8 hours only, certain patients who are very enthusiastic might keep it for a longer time. So imagine if I give a 15 to 20%, I tell the patient wear it only for 3 hours, but the patient wants a faster result, they might use it for a longer time. So it is always safe to give a lower concentration rather than a higher concentration. This treatment is carried out by the patient themselves, but it should be supervised by the dentist during recall visits. That means the patient has to keep up with the dentist, has to visit the dentist. The dentist should evaluate the changes that the bleaching has given to the patient. And once the patient is satisfied, we'll stop the procedure. Again, indications: mild stains, age-related discoloration, mild tetracycline stain. Everything is mild, mild, mild. Stains from smoking tobacco. Imagine the patient wants to cessate the habit. Patient wants to break the tobacco habit. He might come to you. You do a prophylaxis, educate him, and once he is satisfied with the smile, he might discontinue his habit. Color changes related to pulpal trauma or necrosis. Contraindication: pregnant and lactating patients should not try it. Teeth with larger anterior restorations, severe staining, fractured or malaligned teeth. Malaligned teeth are not allowed because malaligned teeth, placing of tray will not be possible. Placement of tray will not be uniform. Teeth exhibiting extreme sensitivity to heat, cold, or sweet. So never for an individual with sensitivity. Teeth with opaque white spots. Teeth with opaque white spots, if you do bleaching, these white spots will become even more demarcated. So it is contraindicated in such individuals. I'll quickly go through the steps of tray fabrication. The patient has come to you. Patient has accepted the treatment. We take an impression. The impression can be sent to the lab and you take the shade so that for our record as well as for patient record. And then we send the tray to the lab. We will tell them the thickness that is needed. They will apply a separating medium like this, by which on all the teeth which needs to be, or all these teeth which need to be bleached. Why we give this spacer is because this spacer is the area where the bleaching agent is going to house, and this is where the bleaching agent will be applied, and then the tray will be placed inside the oral cavity. So trim it in the dental office. Once it is delivered, try the check-in. make the patient understand how it is to be placed, how it is to be removed, how the gel has to be applied, how to place it, and how to clean it. Definitely. That is a very important portion. Majority of the time, they will apply the gel, they'll place it inside the oral cavity. When they get up in the morning, they'll remove the tray, keep it aside, and then go with the regular stuff, come back, and then they may apply another coat of gel and again place it. No. This has to be taken. We have to take proper care. The tray should never fracture. The tray should be neat and clean. Each time the gel that you apply should be washed off. If not washed off completely, should be brushed and cleaned before we apply the next gel into your tray. Hope these steps are clear. Instructions to be given. I have said certain instructions already. Instruct you to brush his or her teeth prior to application of the tray. Place enough bleaching gel inside the tray to cover the facial surface of teeth. That can be evaluated by looking onto the mirror. Excess bleaching material should be wiped off. Once the tray is placed and the gel falls out of the tray, use a tissue paper to wipe it off completely. Never a wet one, preferably a dry one, because the wet one will dilute the agent that is applied, by which we will not have sufficient concentration that comes in contact with the teeth. So always use a dry tissue to wipe off the excess. The tray should be worn for a good period of 4 hours for each session. 4 hours at least minimum, the tray should be applied continuously. After every bleaching session, patient should be instructed to rinse off the bleaching agent from the surface of the teeth as well as from the tray. The tray should be gently brushed to remove the bleaching agent. Result can be seen as early as 2 to 14 days or may take a longer time, maybe 6 to 12 months. The patient should be well informed about the treatment outcome. But I personally tell you, 2 to 14 days, the patient will start to appreciate. By about a month's time, the patient will say or we might be able to discontinue the treatment in 1 month or 2 months' time. This is a small chart about how long it should be applied so that you get a good result. You can see a normal individual 2 to 3 weeks is enough. A darker one, again, as I said, 2 to 3 weeks or a month is max. Moderate tetracycline strain alone, a long-term application might be needed. These are the commercially available agents which can be used for home bleach technique. Advantages: simple and fast for the patient, simple for dentist to monitor, it is cost effective, not usually a painful procedure. Disadvantage: patient compliance is mandatory. Imagine we do all this and the patient is not compliant. He might forget to place the tray and then he wants a result, is difficult. Color change is dependent on amount of time the tray is worn and chance of abuse by using excessive amount of bleach for too many hours per day. This is what I said. When we explain this to the patient, always give us lower concentration because over enthusiastic patients might use it for longer hours. And imagine if the percentage is high, it can be detrimental to the teeth. So with this, we finish the vital bleaching part and we slowly move on to the non-vital bleaching part. Non-vital bleaching part, the first and foremost thing to remember is the tooth is root canal treated. So we call them as intracoronal bleaching. It involves the use of chemical agent within the coronal portion of an endodontically treated teeth to remove tooth discoloration. The method most commonly employed is called as walking bleach, or it can be modified by thermal or photo technique. Indications: discoloration of pulse chamber origin, dentine discoloration, discoloration not amenable to extracoronal bleaching. I'll explain what each are. First one, what they say is, if the access opening is not done properly, and if we have not removed the pulp horn area, then after some time, even after giving a good coronal restoration, the patient might come back after some time because of discoloration. That discoloration is because we have not completely removed the pulp horn area. Dentine discoloration, naturally, as I told you, a root canal treated teeth is devoid of blood supply. Hence, the tooth starts to get discolored. How does it happen? Especially in an individual where the tooth is discolored because of trauma, what happens is, on a hit, the blood that is present inside the tooth gets clotted to form and then it breaks down into iron, by which the tooth appears to be discolored. Next is, you do an extracoronal bleaching and still there is no change, then the primary indication is to do a intracoronal bleaching. Contraindications: superficial enamel discoloration, defective enamel, presence of caries, discolored composites. If imagine if it's an enamel issue, bleaching alone will not suffice. Same thing, presence of caries, remove the caries completely, do a proper restoration, it should suffice. Discolored composite, remove the complete restoration, redo your restoration and see. If the restoration is all that is needed, the bleaching itself can be avoided. Now I'll explain about what is walking bleach technique. It is placing a bleaching agent inside the pulp chamber. And as I previously said, sodium perborate is the material of choice. Sodium perborate can be mixed with distilled water or it can be mixed with hydrogen peroxide, and it is left inside the pulp chamber for a period of days. You can recall the patient, open the seal, replenish the material till the desired shade is reached. I'll explain it once again. It is a root canal treated teeth which is discolored. That means we remove the post-endodontic filling that has been given. We create a barrier. On top of the barrier, we place sodium perborate with distilled water or with superoxide or hydrogen peroxide. We leave it inside the pulp chamber for some 1 week or 2 weeks. Imagine the shade change is not satisfactory. You replenish the material. You wash out the agent, give a new agent, give a new seal till the shade is satisfactory. This technique is known as walking bleach technique. I will explain it to you with pictures. Diagnosis must be made following thorough evaluation of etiology and origin of stain, as previously discussed. Imagine if I see a tooth like this, I should see whether it's a composite that is discolored or the tooth itself is discolored. You can see that the tooth itself is discolored. You can confirm that there is an access cavity that has been done on the lingual aspect. History taking will give you that the patient will give you a history of root canal treatment. So first thing to be diagnosed or to be confirmed is the endodontic status. How good is the root canal? You have to confirm it with a radiograph to show that, to see that the root canal is completely obturated. There is no periapical lesion associated with it. Clinically, it is sound. Existing coronal restoration needs to be checked for quality and shade. Then clinical photograph and the beginning with a shade tab has to be taken. Once that is done, a rubber dam isolation is mandatory. You have to do a rubber dam isolation. And then the access cavity has to be refined. Remove all the restoration. Remove the gutta percha also till the CEJ. How do you measure the CEJ? You should use a graduated probe and see how deep the CEJ is. And based on that, you should remove a little bit of GP also. Then you place a material into the access cavity, which should be at least 2 millimeter thick. I will explain what is the importance of it. Then you place sodium perborate, either mixed with saline, water, anesthetic solution, or hydrogen peroxide to achieve the consistency of a wet sand. And pack it in. Excessive bleaching agent should be removed. Paste should be carefully dabbed with cotton pellet without removing too much moisture. A temporary filling material is of around 3 millimeter thickness is placed over it. A small change, instead of temporary filling material, I prefer glass ionomer cement because there should not be any leakage. If some leakage happens, then the whole process goes for a toss. I will repeat it once more. Imagine the tooth is discolored. Confirm it is endodontically treated. Look for the endodontic status, that there is no infection associated. Remove the coronal seal that you had given. Take photographs with a shade tab. Then you put a rubber dam and isolate. Remove the restoration. Remove some amount of your root canal filling material also and sealer. Then you place a material of about 2 mm thickness. Usually MTA or GIC can be placed. It is known as a barrier. And on top of the barrier, you're supposed to place sodium perborate, which can be mixed with water, saline, anesthetic solution, or hydrogen peroxide. In a wet sand consistency, remove excess, damp it with a cotton pellet, and then you give a post-endodontic restoration so that the bleaching agent that you have applied stays within the tooth and gives you bleaching. This is how diagrammatically it will look like. Endodontically treated teeth, we remove GP till here, we apply or we place a barrier, and then on top of the barrier, we place the bleaching agent. This is again a barrier. There are two ways of placing the barrier. I'll show you in the next slide. Here you can see it is placed as a block. Here you can see there is a small dip, which is known as a bobsled kind of technique for placement, by which more amount of bleaching agent can be hosted inside the access cavity. The barrier is mandate. Radiographically, it will look like this. You have a root canal filling, you have a barrier here, you have the bleaching agent, and you have the temporary filling. CEJ is the level to which GP has to be removed before you place the barrier. This is how cross-sectionally the tooth will look like. Why the importance of barrier is the explanatory part which I will give you here. The most important or the most significant complication that usually happens because of bleaching or intracoronal bleaching is resorption. It is not internal, it is not external, it is specifically called as cervical resorption. You can see how the dentinal tubules and enamel lamellae are aligned here. Imagine you are placing the hydrogen peroxide, sodium perborate material with hydrogen peroxide here. It can easily permeate through here, by which the tooth can get damaged. So the most important complication of intracoronal bleaching or of walking bleach is external root resorption. To counteract external root resorption, we have to place a barrier. How do we measure it? We can measure it by placing a periodontal probe and measuring the depth of CEJ. Then you transfer the same length inside the teeth, by which we will know to what mm you are supposed to remove the restoration and the GP, and then place your bleaching agent. This is a barrier here. This is a barrier which is being placed here. And you can see the barrier covers the most critical area, which is the cervical dentinal area, by which resorption can be taken care of. Now, to ascertain the change that can be available, this is a non-vital bleaching case of tooth number anterior teeth. This is an inter-appointment of image that was taken, and you can see the final result. It is almost similar to the adjacent teeth. One more case of non-vital bleaching where you can see the shade change was anticipated. You can see the barrier being placed, temporary seal being given, and you can see the change that was possible after the treatment. One more case of non-vital bleaching, again a root canal treated anterior teeth, shade was matched, barrier was placed, then the medicament was placed and the tooth was sealed. Inter-appointment review was first visit, second visit. By around third or fourth visit, we were able to achieve the shade change that was needed by the patient and clinically acceptable for us also. Now, modification of walking bleach came because, as I said about vital bleaching, there are certain patients who would want bleaching to be over in a very fast time. So in those individuals where we have to give a faster result, you can apply heat or light. How do we apply heat? Is just like the previous technique itself. After remove the restoration, give a barrier. After that, you place hydrogen peroxide inside the chamber, and then the temperature of hydrogen peroxide is elevated by a heated wand or by application of light. What will happen when you place a heated wand at 50 to 60 degree? The temperature of the agent increases. The reaction is the chemical reaction is triggered, by which you attain a bleaching. So if the tooth becomes sensitive, kindly discontinue, because if the tooth is a root canal treated tooth will never be sensitive. But if the patient says of any pain or discomfort, that means that the heat that you are applying is improper and the material is permeating through, by which it can cause damage. Bleaching should be, if you are using this technique, it should be limited only for 5 minutes. Don't expose it for more than that, because 5 minutes itself, as you are using a heated wand, 50 to 60 degree will be delivered at the tip, by which the chemical agent will be, the rise of temperature will be that fast. The temperature of the oral cavity is around, it is something in a range of around 25 to 30 degree. A 50 to 60 degree will be appreciable inside the oral cavity, just like a burn can happen. So be careful. This is advocated only in individuals who want the treatment to be done at a faster rate. This is another technique where a modification was brought in, where again accelerated bleaching was necessary, In that kind of a patient, we do the same technique. We place a barrier, we place the agent, but we leave it open. And we give a patient a tray also, so that the patient can apply the tray by himself. The gel will be applied extracoronally as well as intracoronally for bleaching to happen. Advantages: surface area will be more both internally and externally. A lower concentration of 10% carbon peroxide is used. Technique will eliminate the chance of resorption. Need to change access cavity dressing can be eliminated, and treatment will be reduced to days than weeks. Disadvantage, as in the beginning, the first thing, as I said, the biggest risk is potential for cervical resorption. Is still reduced, but still exists. So over bleaching by overzealous application should not be done. When you think the result is acceptable, kindly stop the procedure. Don't overextend your procedure. But this is just the same explanation of what I said. What are the merits of non-vital bleaching? They are predictable, simple, quick, and cheap, and it conserves tooth structure. Why? Easily, the doctor can say, why don't we go for an aesthetic crown? Why do you want to do a bleaching? So usually this is indicated for individuals who don't want a crown. It's a single tooth which he wants to retain as itself are the individuals who should be selected for walking bleach technique. Next is laser assisted. Everything is the same. The only difference is the agent that we have will get activated when we apply that particular wavelength of laser. Technique is the same, or the mechanism is the same. Laser applied on the gel, heat is produced, heat activates the bleaching agent. Laser principally works by activating the catalyst, which in turn causes release of nascent oxygen. Types of lasers which are commonly used: carbon dioxide, argon, NdArg are the commonly used lasers. And this is important. Imagine if you have a laser in your practice, this is the setting that you should use when you use your laser for bleaching. There are two mechanisms mentioned, photochemical and photothermal. And you can see the change in nanometer. Photochemical means application of light, activation of agent, low exposure. Activation of light and heat energy, you need a higher wavelength of laser. How do lasers work in bleaching? Laser provides energy for hydrogen peroxide to break down into water and oxygen, releases oxygen into the stained tooth, catalyzes oxidation reaction. Free radicals of oxygen liberated in the process breaks apart the double valency bonds into simpler, more stable, less pigmented chain. Same chemical reaction as I explained for hydrogen peroxide. Advantages: faster because it is high concentration. It may act as a jump start for a difficult case by helping to remove difficult stains like tetracycline and fluorosis. Disadvantage: expensive because the laser itself is expensive. Procedure is time consuming. Post-operative sensitivity, high chances of post-operative sensitivity. Now I will go on to the last phase of it, which is over-the-counter ones. You get these kind of strips which are made of hydrogen peroxide, which the patient can use at home itself. Advantages is they are trayless, they are adhesive with 5.3% hydrogen peroxide gel, which are to be applied on the facial surface of the teeth 30 minutes twice a day for 14 days. Initially, the dentist can guide it, or you can also give it from your dental office, but the result again is not predictable. Problems are erosion of labial surface if not applied properly. If applied on exposed dentine, the dentine can appear darker. Patient may overuse this agent to overachieve the white color on the tooth. Now, I think I am overextending, or I think the discussion is going on for a long time, but I will cut short my discussion very fast. Common problems that are usually that we see with bleaching are: first and most important is tooth sensitivity. It is the commonest side effect that happens whenever we do bleaching. Excessive use or overzealous patients it's commonly seen, which frequently causes thermal sensitivity reported as high as 67%. occurs 2 to 3 days after wearing the tray, and patient is advised to discontinue the wearing of their trays. How does it happen? Dentine consists of round tubules. Movement of fluid in the tubules triggered by temperature change and difference in osmotic pressure simulates pain fibers, by which the patient complains of sensitivity. Options for treatment: active treatment for patients with normal sensitivity. Fluoride paste can be placed in trays and worn for alternate nights. Desensitizing toothpaste should be given. Neutralized with sodium fluoride gel in trays overnight. Potassium nitrate or fluoride gel can be given. For patients with history of sensitivity, 2 weeks prior to bleaching, brush with desensitizing paste. Neutral fluoride in bleaching trays applied to teeth 3 weeks prior to bleaching. Begin to wear empty trays for 1 hour a day for first week to overnight on second night. That means it is for patients who already have sensitivity. Please ask them to start on a desensitizing regime before we start bleaching, so that the sensitivity issue will be at a lesser rate. Passive treatment: removal of excessive bleaching material, usage of lower concentration of bleaching gel, usage of less bleaching material in the tray, and insurance by the tray. Next is alteration on enamel surface. I told you about what will happen on the enamel surface. There is a point known as saturation point. If you cross saturation point, these are the things: increased porosity on the superficial enamel structure, demineralization, decreased protein concentration. 10% carbamide peroxide treatment showed enamel hardness. Effect on dentine: concluded that direct exposure of 10% carbamide peroxide causes significant decrease in flexural strength, thickening, that is carbapol or glycerin. Not just 10% carbamide peroxide caused a decrease in dentine micro hardness. Now I will jump from this to composite. This is very, very important. When do we do a composite restoration after bleaching? So it is said that a significant decrease in surface hardness happens on bleached composite resin. So application of 10% hydrogen peroxide or 30% hydrogen peroxide resulted in composite color changes. So imagine the patient came for a bleaching. The existing composite restoration shade can change. So you have to be very particular that you might not apply gel on those teeth initially. And only if the shade is not matching, expose them to bleaching agent. Next is bonding. When do we do a composite restoration? The residual oxygen following bleaching procedure is an adverse effect for bonding. It will not allow polymerization of resins to happen. It is prudent to completely eliminate residual hydrogen peroxide before restoring the tooth with composite. So what can we do? We can apply vitamin C onto the tooth surface, or you can scrub it with 90% ascorbic acid. Next comes the most important question: when do we do a restoration then? You should wait for minimum 2 to 4 weeks before we do a composite restoration if the patient gives you a history of bleaching. Effects on amalgam restoration: more mercury release have been noted after bleaching. Prolonged treatment with bleaching agent may cause microstructural changes. Existing amalgam may cause discoloration. Effect on soft tissue: I had shown you the picture, what can happen on the surface. Rehydration: application of antiseptic ointment if the tissue is exposed. Imagine, just like the previous case, if by accident the soft tissue is exposed, don't rub the area with the tissue, don't rub the area with the cotton, don't touch the area. Ask the patient to apply, rehydrate this by giving surface gel, by which the gel will give or placement of antiseptic ointment. Now, again, I just wanted to stress on bonding a little bit because this is a common error that I see after bleaching. So high significant reduction in bond strength of GIC to dentine is also seen after hydrogen peroxide treatment. High significant reduction in bond strength of composite to enamel is seen. No measurable addition of composite to dentine treated with hydrogen peroxide. Bond failure was cohesive as well as adhesive. There are basically two changes that happens. Whenever I teach my students, I tell them cohesive and adhesive. I give them the example of a glue that is used to stick two things together. That is what is known as adhesive, where you have an agent in between, and the agents that we stick are two different materials. Cohesive means you don't need an adhesive. They are two materials of same composition. So damage will happen within the composite, as well as damage will happen between the junction of the tooth and the composite. So suggest hydrogen peroxide affected is setting of bonding resin and in addition to filled resin. So as mentioned previously, if going for a restoration, you have to wait for minimum 2 to 4 weeks. This is something which I had to say. Don't discard these papers that come along with the branded material that we use. It will have everything that you need to know. I don't know how many of you keep it safely. I have the habit of picking them and filing it up because my boss or my professors used to tell me there are certain things the brand will tell you, there are certain things the brand will not tell you. But whatever is necessary will be there in this. So kindly read through these instructions thoroughly before you use your material. So coming to the terminal end of my presentation, that will be my conclusion. Bleaching is an important and valuable adjunct. I use the word adjunct because it is an aesthetic treatment. And it is not a mandate, but we usually give it to patients only because they demand for it. So proper diagnosis, selection of bleaching material, placement technique, and an understanding of the biological interaction with soft and hard tissue are all factors that determine not only immediate success, but also long-term success, safety, and patient satisfaction as well. So diagnose thoroughly, understand the problem, and do it safely. These were some of the references I had taken for doing this presentation. I sincerely thank you for giving me this platform, and I hope I was able to deliver from my side to you. Thank you.